Welcome to Plenary Lecture 5. I'm Kazutaka Ikeda, CINP President-elect and Chair of the Local Organizing Committee for this Congress. It is a great honor for me to serve as the chair of this plenary lecture featuring Professor Belinda Lennox, the chair of the Department of Psychiatry at University of Oxford. As you know, the University of Oxford is ranked as the #1 university in the world. Professor Lennox is a distinguished expert in the field of psychiatry, known for her groundbreaking research and clinical work. Her research focuses on the causes and treatment of severe mental illness, particularly psychosis. She has made significant contributions to our understanding of the immune basis of psychotic disorders, exploring the intersection between neurology and psychiatry. Professor Lennox's work has not only advanced scientific knowledge, but also improved clinical practice and patient outcomes. Today, Professor Lennox will be sharing her latest research findings and insights into the mechanisms underlying severe mental illnesses and discussing potential new avenues for treatment. We are privileged to have her with us today, and I'm certain that her lecture will be both enlightening and inspiring. Please join me in welcoming Professor Belinda Lennox.
Well, thank you so much for your kind introduction, Katsu, and thank you to the organising committee and the CINP for inviting me along. It's a huge honour to be here. So I will tell you a bit of the story, I guess, around the development of my research idea and where we've got to, and I hope something that might be relevant for everyone in the audience. Those are my contact details. I'm always very happy to collaborate and discuss with people because actually sometimes these patients are very severely unwell and the treatment pathway still is not clear in most places around the world, and I'm happy to try and help with clinical cases. And I'm still on Twitter, or X, just about. Okay, my conflicts, I do get consultancy for Johnson & Johnson and Arialis Therapeutics. So the starting point, this is where I come from, so the University of Oxford, as Katsu said, is supposedly the leading university in the world. It's a very beautiful place, it's a very ancient place, and it does have a reputation for world-leading medical research that translates through to benefits for society. But the reason I went there is actually, you may not know if you're not in the field, but it's had a world-leading reputation for neuroimmunology research for really the last 30 years, and that's largely down to this woman in the bottom right there. That's Professor Angela Vincent, and she spent the early part of her career really defining myasthenia gravis as an antibody-mediated disorder, as a treatable neurological disease. And she was the first one back in 2001 to describe initial cases of patients with an immune-responsive CNS disorder for the first time. And it's quite interesting just to tell you the story behind that, because this was with clinical colleagues. So Angela led the neuroimmunology research laboratory at the John Radcliffe Hospital at the West Wing, which is there on the bottom left-hand side. And the research lab is alongside the clinic. And they had patients who presented with limbic encephalitis, patients with very difficult to treat seizure disorders, patients with dense progressive cognitive disorders, and they identified antibodies in those patients. And to demonstrate the sort of reversible nature of it, they gave these patients plasma exchange. And plasma exchange is basically a plumbing intervention. So you flush out the patient's plasma and you take out large molecules. So it's not a drug, it's not an intervention in any way. You're just filtering out the patient's plasma and taking out antibodies, essentially. And the patients recovered, their cognition improved, their seizures stopped. So that was a direct demonstration that really it can only have been the antibody in the patient's serum that was causing this disorder. So it was a sort of a clinical research application. I mean, this wasn't done as part of any kind of controlled trial. It was just scientifically principled, but it demonstrated that a patient's situation was reversible with this treatment. And that was the first time that this was described, and it's really spawned a whole field of really sort of expanding. Every year a new antibody is described, really, and it's accepted in neurological practice, absolutely, that these patients have treatable causes for their sometimes profound neurological disturbance. So that's what's happened over the last 25 years in neurology, whereas in psychiatry, we really haven't kept up, or we haven't had anything in parallel. So this is where I work in Oxford in the 21st century. It's a Georgian hospital. It's the oldest hospital that has continually treated patients since it opened in 1812, and it still sees patients with mental illnesses today. So we just don't have the shiny neuroscience facilities. We have no ability to do plasma exchange on patients, even if I think they may have a really interesting, potentially reversible disorder. I've got no ability on the wards to give patients infusions or to do any level of investigations, really. So we're a long way behind, and we're sort of separate in our cultures as well as separate in our buildings and institutions. So I'll tell you today, my clinical work, my research work is all in psychosis. So I apologize for people not interested in psychosis and schizophrenia, but if you're not, maybe you should be. So schizophrenia is a severe mental illness that has a prevalence of about 1% and is seen in populations worldwide, affecting 24 million people in the world. It has an incredibly high morbidity, and that's because of the onset in adolescence. So it's very costly to economies, it's costly to individuals, it's costly to families. Half of all inpatient beds are with people with schizophrenia. And it has a high mortality, particularly because of the associated cardiometabolic disease associated with the disorder. So it's a big problem, it's a public health problem, really, and it's worldwide. It's also firmly, I would say, a brain disorder. It's a sort of act of history and an act of fate that schizophrenia has always been a psychiatric disorder, although it is a neuropsychiatric disorder, I would say. So a combination of the positive symptoms of psychosis alongside the negative symptoms, and notably the cognitive symptoms that we've heard about in this conference already, that are really the most disabling, functionally impairing symptoms of the disorder, and also more frank neurological symptoms and signs that you can see when you look for them. So my clinical service, I work in an early intervention in psychosis service, and I'm very proud to do so. We can demonstrate really good functional outcomes for our patients that we see, and we offer a holistic package of care. We look after the individual, both giving evidence-based medications. We use atypical antipsychotics and then move quickly to clozapine if people aren't responsive to that. We give individual psychological therapies with cognitive behavioral therapy for psychosis. We look after families. We give, again, evidence-based family therapy. We get people back into occupation. We give employment placement support, individual placement support to get people back into employment. And we look after people's physical health. So this is a wonderful multidisciplinary team effort. And we really look after people, I would say, with kindness, and we look after the whole person. But what we do is manage the symptoms of the disorder. We do nothing to investigate and actually say, well, maybe we can understand what caused your illness, or maybe perhaps even treat that cause. We're managing the symptoms, and we have no ability, we have no biomarkers, we have no diagnostic tests to be able to say what somebody's outlook is, or who's going to respond to which treatment, or whether somebody has a different form of an illness to another. So first of all, in this talk, I suppose I'll persuade you that it's not such a ridiculous idea that actually a proportion of schizophrenia might be autoimmune in basis. And actually, standing back, I can't think of another area of medicine where a proportion of illness isn't autoimmune. So maybe it's not such a strange idea that a proportion of mental illness should also have an autoimmune basis. So the first clue comes from our genetics. We're very proud in the schizophrenia field of our wonderful, highly collaborative, global genetic studies. This is the GWAS study from a few years ago now of over 40,000 patients and controls, showing strong signals both for glutamate signals in the black there, calcium channel signals, but also adaptive immune system clues. So the major histocompatibility complex, that huge, great towering association there, and also CD19 and CD20. So B-cell related genes that are important for the production of antibodies. Another clue comes from the epidemiology of schizophrenia. This is the population of Taiwan, which I particularly like. It's broken down by sex, so males and females with a differential risk across the two for multiple autoimmune disorders in people with a diagnosis of schizophrenia, and across all kinds of parts of the body. So it's not just CNS disorders, so an increased risk of type 1 diabetes in females with an odds ratio of about 2, an increased risk of celiac disease, again, greater in females with an odds ratio of about 4, and also often replicated and mysterious lack of association, a negative association with rheumatoid arthritis. You have half the risk of developing rheumatoid arthritis if you have pre-existing schizophrenia, which I just think is such a fascinating clue into the etiology of the disorder. To take that finding one step further, this is the work of Michael Benros and colleagues in Copenhagen, and he looked at the whole of Denmark because they can do that. They have wonderful population registries that they can link up every hospital contact, every prescription, every diagnosis across the whole population. And they showed an increased risk of people, so looking from the other direction, if you have a pre-existing autoimmune disorder, you have an increased risk of developing later schizophrenia. And that increased risk was further increased if you were admitted to hospital with an infectious illness. So that could be any infection, but it was severe enough to warrant admission to a hospital. And I like this finding particularly because it shows a stepwise increase. So the increased burden of infection results in an increased risk of later schizophrenia, and that's further increased if you have a pre-existing autoimmune disorder. So it's a bit more of a direct link between infection, immunity, and schizophrenia. And I suppose we can't really give any talk today without talking about COVID. And this is, I think, the elegant work from Max Take and colleagues in Oxford, who looked at the electronic health records of 1.5 million people who'd had COVID in the States and compared with people admitted to hospital with the same severity of illness with other respiratory infections, and showing the increased risk of various neuropsychiatric disorders 6 months later. And the psychotic disorders is at the bottom here. And they divided it up by age range to show that particularly increased rate of psychosis in young people. So under the age of 18, you have a hazard ratio of 2, but it's still increased in adults and even a bit higher in older adults as well. But again, a sort of very interesting direct link perhaps between infection and a psychiatric diagnosis. So you might say, well, there are plenty of people who might have schizophrenia and other immune disorders, and they will be treated with anti-inflammatory drugs, and maybe we could get some clues about their treatment response to their psychosis if they're given those immune treatments. And some work has been done on that, but the studies I'm presenting you here are the direct research studies, the randomized controlled trials of anti-inflammatory drugs directly tested in people with psychosis. And overall, I would say they're a bit disappointing. So you can have sort of anti-inflammatory drugs, COX-2 inhibitors, that the studies show wide variation of results here. Or there's the tetracycline antibiotic minocycline that gets into the brain, that there was a great excitement to start with this initial study of Chowdhury et al. To show quite a strong positive effect, particularly on negative symptoms in schizophrenia, but subsequent larger studies have not shown any effect. There's been one study of the IL-6 monoclonal antibody tocilizumab, which showed no effect at all. And this drug, fingolimod, which is used in relapsing remitting multiple sclerosis, again, a small study, but potentially showing a small effect. So overall, nothing very dramatic. But I would say that the issue with all of these studies, and I suppose in psychiatry trials in general, is of course the heterogeneity of the population you're picking for these trials. Nobody is claiming that 100% of psychosis or schizophrenia is going to have an autoimmune basis. So if your studies are diluted out by 80 or 90% of people who perhaps are never going to benefit from the drug, it's going to be very difficult to show a specific effect in those that do. Okay, so then I'll tell you a bit about the science behind autoimmune encephalitis, because all of these supporting these sort of decades of research really showing clues that autoimmunity may play a part haven't translated through into clinical practice. We've had no ability to personalize, stratify, identify the patient sitting in front of us who may have an autoimmune basis. Even if you have a young person with a very strong family history of immune disorders who may have a personal history of an autoimmune disorder and presents with a first episode of psychosis, you're not going to do anything different. Well, I'm not going to do anything differently at the moment. I'm going to give them the same symptomatic treatment as everybody else. But the findings and the science that really has transformed neurology, I think now is well placed to actually influence our field as well. So this was the first case report. I thought I should show this here because this is actually from Dr. Hitoshi Okamura from the Department of Psychiatry, the National Cancer Center Hospital in Tokyo. And I think this is the first published case report of what was later then identified as an NMDA receptor antibody encephalitis. So this was over a decade before the antibodies were actually identified, but it gives a good feeling for the disorder. So this is a young girl, and she'd been well until July 94 when she developed impairment of recent memory. She gradually lost contact with reality. She became acutely confused and was transferred to a psychiatric unit. On admission, she had a stiff facial expression, incoherent thoughts, and was dismissive. We could not communicate with her at all. On physical examination, a mass was palpated in the lower abdomen. Neurological examination was unremarkable. They also did investigations. An EEG showed some slow wave activity, an MRI was completely normal, and a lumbar puncture also was completely normal. There's no inflammation in the CSF. So this is a very characteristic psychiatric presentation, really. There's no gross neurological changes at all. There's nothing that you can hang your hat on that this is anything other than a psychiatric presentation, other than this mass in the lower abdomen. So they operated, and it was an ovarian teratoma. They removed the ovarian teratoma, and over the subsequent 2 weeks, the patient made a complete recovery. So this was an amazing observation of an association between a benign tumor and a psychiatric presentation. So then fast forward 10 years, and Joseph Dalmau and colleagues then described the antibody associated with this very characteristic presentation as being antibodies against the NMDA receptor. And now that is the most prevalent, most common, well-known across the world, really, as being the leading cause of autoimmune encephalitis. So why are these antibodies so transformative and so important, really, for all clinicians to know about? Well, it's because they're antibodies against neuronal cell surface targets. So they're considered directly pathogenic for the underlying clinical presentation, and they're also considered reversible and treatable. The way that we test for these antibodies is just worth dwelling on just for a minute. So labs across the world will put patient sample onto neuronal cultures here in the bottom there, which are grown from rat hippocampal neurons, and then they put the patient sample on and look for binding, look for this sort of punctate pattern of antibodies sticking to the neuron. They will put patient sample onto rat brain slices and look for staining and look for particularly hippocampal area staining. And the key way that we diagnose and test for these disorders are very specific cell-based assays. So we grow human embryonic kidney cells expressing just the protein, just the antigen that we're interested in. So these are highly specific tests. So you'll have a different test for each different antibody, and it's considered, there's no really such thing as a false positive. If you get a positive binding for the patient sample to that cell, it can only be binding to that particular receptor. So highly specific and also highly sensitive tests. So for the first time, we have a diagnostic test for this brain disorders. So the phenotype, the clinical characteristics of NMDA receptor antibody encephalitis is now well known and well described. It's still a very rare disorder. So the incidence is about 1 per million per year. So in the UK, that's about 60 million a year. So 60 people a year. So, every neurology centre will be alert to it and will want to pick it up quickly when they present. This is the European case series data from Sarosh Irani and colleagues in Oxford. It's about 450 patients, and it's to show the time course of the symptoms. So each dot is an individual patient, and it shows firstly that this is a really rapid illness. So from first symptoms, first presentation of day 0 to a life-threatening autonomic dysfunction is about 3 weeks. The initial presentation in about 3/4 of patients is to psychiatrists, and it's with psychiatric symptoms of the kind described in that case report. The second most common presentation, well, almost ubiquitous presentation, is with cognitive dysfunction. So patients will present with amnesia, with confusion, and they will have seizures as well. The seizures are not often very prominent, actually, so you might just get 1 or 2, so they can often be missed. And then after a couple of weeks, you get this invariable progression of symptoms to a characteristic movement disorder, which is to all intents and purposes catatonia. And then you get the scary, frightening bit. You get a loss of consciousness, and you'll get breathing dysregulation, blood pressure, instability. Before these antibodies were diagnosed and treated, these patients would have a very poor outcome. So about 1/4 would die, or you would be left very severely impaired. The way of diagnosing the disorder, the only way of diagnosing the disorder, is to find the antibodies in the CSF. And really, it's a remarkable illness for how little else you find. So absolutely typically, patients will be investigated very thoroughly. They will have all kinds of blood works, they will have scans, they will have EEGs, and more often than not, all of those investigations will be normal. But if you look in the CSF, you will find the antibodies, and you will usually find inflammation as well, although not always. So you'll find lymphocytes, or you'll find oligoclonal bands, and again, very early on. And it's a treatment-responsive illness. So this is a meta-analysis of published case reports of 1,500 patients with NMDA receptor antibody encephalitis. And again, it's all observational data because there haven't been any randomized controlled trials of treatment. But here it shows the impact of the initial treatments, and maybe you can't see the individual treatments, but it doesn't actually matter too much. They're all pretty much as good as each other. And the standard treatments are either steroids or intravenous immunoglobulins, or TA with therapeutic apheresis or plasma exchange, or a combination of those things. So pretty much anything you do is good, but doing nothing is bad. So that's the summary for that. And then after the initial treatment, the most effective way to stop a relapse is to give rituximab. So rituximab, a monoclonal antibody against CD19, 20, anyway, suppresses B cells to stop antibody production, and it's highly effective at preventing relapse in this disorder. So for the last 15 years or so, I have been intrigued by this illness because it just seems so apparent to me that this illness overlaps almost completely with what we have seen and what we know as part and parcel of schizophrenia, and actually always has been. So as well as the initial clinical presentation, which is essentially an acute florid psychotic presentation, all of the other characteristics are also described in schizophrenia. So seizures actually have been recognized always, even pre-antipsychotics, as being associated with schizophrenia. They were described by Kraepelin as being the initial presentation of dementia praecox in about 1 in 6 of his patients. Cognitive dysfunction, as we know, is a core feature of the illness. The movement disorder, catatonia, again, we all recognize that that is a part of a severe schizophrenia illness, even if perhaps we don't look for it and monitor for it quite as well as we should. And even the more catastrophic part of the illness, the autonomic dysfunction and the loss of consciousness, we call it neuroleptic malignant syndrome. We blame the drugs. But actually, maybe this is an underlying encephalitis. And in the UK, we don't do lumbar punctures. Most of the world don't do lumbar punctures in patients with psychosis. But in Germany, they do much more regularly, and they find actually inflammatory changes in about 20% of patients with psychosis. So maybe we've been looking through the wrong lens all along. And of course, this was captured brilliantly, I think, by Susanna Cahalan. And for anybody that doesn't know her story, she was a New York Post journalist who had an episode of psychosis. So she started believing that her flat was infested with bed bugs. She developed paranoid delusional beliefs, believing her life was in danger and that her father was meaning to kill her. She started hearing voices and seeing things that weren't there. She was admitted to a psychiatric hospital. She was given antipsychotic drugs. She did have a seizure, a couple of seizures, and was given EEG telemetry for that. But basically, she got worse over a period of a month and became catatonic and mute. And the psychiatrists said to her parents, well, we're going to move her into long-term institutional care. And they weren't very happy with that. And they asked for a second opinion from the brilliant neurologist Suhail Najjar in New York. And maybe because it's New York, he did $1 million worth of investigations. This was back in 2010, including a brain biopsy, which I think is probably a first that I've heard of. But he found NMDA receptor antibodies in her brain. She was treated with plasma exchange and made a complete recovery. And she writes about it brilliantly. And this is the original Brain on Fire. But I suppose the thing that really struck a chord with me was, the sort of almost the therapeutic or the etiological nihilism from the psychiatry community. And I hold myself up with that as well. We don't actually look very far with people that are very treatment resistant and extremely unwell. We go through our algorithms of treatment, but that's the end of it. So it takes the neurologist to do the brain biopsy. But secondly, the different approaches, the sort of stigmatized approaches actually to treatment. So one approach, when she had a severe mental illness and was considered slightly to be her fault, there were comments like, well, she drinks too much and she's a journalist, she's very stressed, kind of what do you expect? To having an infection and an inflammation of the brain and a brain injury where suddenly you're deserving of a different approach and it's absolutely not your fault. She writes, how many people currently in psychiatric wards and nursing homes denied the relatively simple cure of steroids, plasma exchange, or more intense immunotherapy? And I think that challenge still remains today. Okay, so now I'll come on to the research that I've been doing over a decade now, trying to find evidence that actually a proportion of our patients with psychosis, with schizophrenia, who've never come across a neurology setting, might also have these antibodies and might also have a treatable cause for their illness. So we started with a very simple idea of just doing a prevalence study of screening patients with first episode psychosis and looking for antibodies. So these are done in these early intervention services that we have across England, which offer a rapid response for people experiencing psychotic illness. So we've right across England, first episode of psychosis, we started off with young people, and we started off looking right at the beginning of illness, so less than 6 weeks of medication, although we've since broadened those criteria out. We also collected healthy population controls with no personal or family history of mental illness, who are age, gender, and ethnicity matched. And we found overall 8.8% of these 228 patients had an antibody of some kind. Some of them had NMDA receptor antibodies, and some of them had these other antibodies. So LGI1 and Caspar-2 are components of the voltage-gated potassium channel complex, those antibodies first described by Angela Vincent 20 years ago. And some also had antibodies against GABA-A receptor, which is a very intriguing finding because GABA-A receptor antibody encephalitis is an incredibly rare disorder. But we also actually found some healthy controls with low levels of some of these antibodies, so that overall there was no difference. But it seemed to be the NMDA receptor antibodies and the LGI1 antibodies, particularly, that we found only in the patients. Since then, we've carried on collecting samples year by year, mostly to feed into our clinical trials. So this is data by year from 2018 to 2024. And I suppose I show it to you just to show that we still find antibody positivity between 5 and 6%, but also to show, I think it's quite interesting, this drop-off during COVID. So as well as a drop-off in total number of patients, of samples collected in 2020, but the drop-off in prevalence rate over halved between pre and post-COVID and during COVID. So something to do, again, perhaps indicating whatever infectious trigger for these antibodies wasn't around anymore, and so no autoimmune psychosis or potentially autoimmune psychosis was occurring. So the next obvious question was, well, we're screening for the antibodies that have been described in encephalitis, but what about the possibility there'll be antibodies only seen in psychosis, that actually we should do antibody detection work, novel discovery assays to look for antibodies only in our patients. So the way that we've been developing this is to develop cortical neurons using iPSC models. So we grow cortical neurons over 70 days, and then we have a careful quality-assured process to detect these antibodies. So we want a robust assay, basically, that's semi-automated, so to reduce observer bias. So there we go. So this is what we find. We've screened over 150 samples now, and each of these samples here is a psychosis patient, X, Y, and Z. And we stain the samples with MAP2, which draws out the neurons, and then we put a secondary anti-human IgG binding on top of any antibody from the patient sample to bring out this nice green immunofluorescence staining. We also test healthy control samples and also encephalitis positive control samples. So here you'll see in the NMDA positive control, you can see a nice distribution and density of antibody binding to these cortical neurons. And you see that there's no such binding in the healthy controls. And you can see some of this and fluorescent color, but it's not attached to any neurons here. So this is almost a secondary control. In the psychosis patients, we see some patients with a good level of binding seen to neurons, and we see some patients where there's no binding seen at all. So we've plotted our 155 patients against healthy controls and against known NMDA receptor antibody encephalitis. And so these psychosis samples are all patients that are negative for all known encephalitis antibodies. So these aren't duplicating antibodies that we already know about. So this is an additional proportion of novel antibodies that we're finding in these samples. And you'll see that there's a distribution. So a large proportion have a very comparable to the healthy control samples, no obvious antibodies at all, but a proportion have actually a very high level of staining and distribution of antibody binding, actually quite comparable to those that we see in NMDA receptor antibody encephalitis. So we see this as a strong indication that there are indeed novel antibodies in patients with psychosis, and we're now rapidly trying to chase those down and identify them. Remember, I told you earlier on that the sort of usual way for testing for antibodies is to use rat hippocampal neurons. So we're also interested to see whether our iPSC model and how it compared to using rat hippocampal neurons. So we did a head-to-head comparison. So we put all of our samples onto a rat model and then also onto our iPSC model. And you'll see that some samples, in fact, all samples that showed positive binding to the rat cultures also showed good binding to the human model, but there were some that showed no binding to rat neurons and showed a good binding, good immunofluorescence pattern on the human iPSC model. Maybe this shouldn't be too surprising that actually humans are a better model system for testing psychosis relevant antibodies than rats. And in our comparison of the sort of rate that we find that are positive, we find about 5% positive on a rat hippocampal neuron, and about 12% of our psychosis samples show novel antibodies on a human model. This is all unpublished data, by the way, so I'm sharing with you, hope of interest. Okay, so this is all, I hope, quite exciting and interesting, but it doesn't actually make a difference to our patients. And the most important question that I'm really desperate to know the answer to is the sort of so what question. Do the patients that we see with the psychosis and these antibodies actually get better with immune treatments rather than antipsychotics in the same way as Susanna Cahalan did and these other patients with encephalitis? So that's what we've been trying to do, and we've been funded by the Medical Research Council in the UK to do a double-blind, placebo-controlled trial of intravenous immunoglobulins and rituximab, which we're still recruiting to, and I hope to be able to report next year. But I can report our sort of preliminary data that fed into that trial. So the first question we were asked by the panel is saying, show us that you can give acutely psychotic, mentally unwell patients, you can give them these immune treatments, that you can deliver infusions in their arms and that they will comply with these treatments. So that was the Synapse 1 feasibility study. We recruited 10 patients from across England, and we said to the neurologist treating them, you choose which treatment you think is most appropriate. So there is a bias there that every patient with NMDA receptor antibodies was given plasma exchange, and the patients with other antibodies, with the voltage-gated potassium channel antibodies or the GABA antibodies, were given other treatments, mostly intravenous immunoglobulins. So these were patients with psychosis. They did not have encephalitis. They did not have seizures. They did not have. They did not meet the criteria from a neurological perspective of having an encephalitic illness, and that's really important to say. And we did PANS scores, positive and negative syndrome subscale scores, at baseline and then 6 weeks after treatment. So the only thing that changed in that time was the plasma exchange or the intravenous immunoglobulins. And you'll see the patients with the NMDA receptor antibodies really responded almost completely to that plasma exchange. So the patient number 3 there with a PANS of 170, who was mute and catatonic, became symptom-free within 6 weeks. And I like this study because not everybody got better. So as strange as that sounds, it's not just some magical part of the intervention. So some of these patients with voltage-gated potassium channel antibodies, this was before the days that we knew you had to test for the specific LGI1 and Caspar-2 antibodies. And we now know that a proportion of patients with voltage-gated potassium channel antibodies actually have intracellular antibodies. So you wouldn't expect them to get better with immune treatments. And that's the case in a couple of our patients. They didn't respond. And also, interestingly, the patient with GABA antibodies didn't respond at all to treatment. But it seems to be that the NMDA receptor antibody is actually very sensitive and responsive to immune treatments. So I was quite excited by this data, and I've been seeing for many years, I hold a joint clinic with neurologists where we treat everybody, whatever their clinical presentation. If they have an antibody and they're resistant to symptomatic treatment, we will offer immune treatments. And we described and, demonstrated that patients got better with immune treatments and not with antipsychotics. But it hasn't changed the world. It hasn't even changed clinical practice in Oxford. And, I'd have thought I shout quite loudly. And it's quite a difficult thing to change systems and change cultures and change practice. And I suppose that's why I've decided that, now all the patients I see are fed into a clinical trial. I think we need that higher level of evidence, a gold standard placebo-controlled trial, double-blinded trial, really. And then nobody can argue with me, I hope. But to try and sort of, I suppose, irritate neurologists, I put our psychosis data alongside their autoimmune encephalitis data. So on the left here is the same European case series data of the 450 patients. And what Sarosh Irani did is he wrote to all of the clinicians treating these patients, and he said, what did you do and what was the outcome? And it's plotted here against the y-axis is the modified Rankin scale. And for those of you that don't know, the modified Rankin scale is a very compressed scale of global functioning. So a 0 is well, symptom-free, and a 6 is dead. So it really is the whole of life in 6 points. And here on the bottom, you've got no immunotherapy or immunotherapy in more than 40 days and immunotherapy in less than 40 days. So if you have encephalitis and you're given immunotherapy quickly, you get better, substantially better. So the difference between being in hospital and being back at work, substantial difference. Our patients with psychosis that we've treated in the clinic, again, they're not as severely unwell, they're not intubated on intensive care units, but they get better in exactly the same way. If they're given immunotherapy, they get better. If they're not given immunotherapy, they don't get better. I'm proceeding with the clinical trial, and it feels very slow. But meanwhile, in Germany, they're far ahead. And they always have been far ahead, actually, because they actually have a much better integration between neurology and psychiatry. Psychiatrists are trained in neurology, neurologists are trained in psychiatry. It's much more natural for them to consider the brain in people with mental illness. And patients with psychosis are investigated with lumbar punctures and with appropriate investigations as needed. This is a case series from Dominic Endres and colleagues, published a couple of years ago, of 91 patients. And these were patients with psychiatric diagnoses, mostly psychosis, where the clinicians suspected that there was an autoimmune cause. And it's divided up into 21, which is considered probable autoimmune cause, and that's because they had a serum antibody, mostly NMDA receptor antibodies. Or else a possible autoimmune cause where they had no antibody, but they had something to indicate to the clinician there might be so that might be an inflammation in the CSF, or that might be changes on an MRI, or that might be suspicion on an EEG, or a combination, or an unusual clinical story. But it's a clinical judgment as to what was going on. And these patients were offered immunotherapy. And it's really striking to me, so everybody really, 93% of people with a serum antibody got better with immune treatments. But look, 80% of people without an antibody also got better with immune treatments. And the immune treatments that were used were high-dose steroids, or plasma exchange, or intravenous immunoglobulins. Very alien treatments for a psychiatrist to be given for a patient with psychosis. In fact, steroids, I think we'd feel pretty cautious about giving those to a patient with psychosis. But in their case series, these patients benefited. So maybe we should be bolder. Maybe we should have these treatments available to us as psychiatrists. And I was very struck by Ludger Teberts van Elst, who leads a wonderful service in Freiburg in Germany. And he said to me, why should we dictate our specialty by the treatments that we use to treat patients? That makes no sense at all. And he brings in the rheumatologists to help with rituximab, or he brings in the blood transfusion service to help with the plasma exchange, but it's firmly him managing the patients and treating them. So that's just a little promo for our clinical trial. Okay, so the future potential. So I really think this is an exciting time. Perhaps we can redefine our disorders, or one of our disorders, through its etiology, and that would be an amazing progress. Perhaps we can use disease-modifying treatments for the first time. And even more importantly, I would say it brings a whole new research world into psychiatry, both therapeutics and basic science. And actually, immunology in general, in the whole of medicine, is the biggest growing area of therapeutic development. And, you know, they should apply some of that to our disorders. And perhaps even more importantly, I think it busts the stigma of schizophrenia and severe mental illness, the most stigmatized of illnesses. So like Susanna Cahalan, move from a position of a bit somehow shameful, or somehow your own responsibility, or something your family has created, to something that is actually just a fault of your immune system, in the same way as rheumatoid arthritis, or the same way as celiac disease. Wouldn't that be a wonderful thing? And it's really sort of captured people's imagination, I guess, and I actually get almost more excitement from the public and from patients and families than I do from mental health services, but maybe that's just the UK mental health services are on their knees, so it's difficult for them to do anything. But you know, this was an article in Science last week, describing our research and others as well, really, I hope, raising its profile. And so I will finish there just by thanking all of my wonderful team and colleagues who've helped to make all this work possible. Thank you.
Thank you very much for your outstanding lecture about the groundbreaking research results changing our textbook in psychiatry. So we learn a lot from your wonderful lecture, wonderful and stimulating and inspiring lecture. So thank you very much indeed. So I'd like to close this plenary lecture. Thank you very much.